The WHO says there are wide disparities in the health status of different social groups in all countries, whether low, middle, or high income. The lower an individual's socioeconomic position, the higher the risk of poor health. Regardless of race or ethnicity, African Americans have a higher death rates than all other racial and ethnic groups for many cancer types. I spoke with Dr. Robert Winn, director of the Virginia Commonwealth University Massey Cancer Center, who is spearheading interdisciplinary approaches to cancer disparities research. Take a look.
When we talk about disparities, that is those differences that can be accounted for not just by biology, but by our structures. And so there's many examples. COVID was an example of, particularly in the beginning of COVID, when we had a difference in Black-white deaths, Black-white uptake in the vaccine. But you know what the funny part is? COVID actually showed us one thing, that when you want to close the health disparities gap, you can. By the middle or almost towards the middle of the COVID, when the vaccines are given, we could see that through efforts that were on the ground in communities, that we closed the Black-white gap in the context of vaccine uptake. We've taken a shorthand of that now. We call it the reason why there's disparities is, quote, social determinants of health. That means that there are some populations, some communities that don't have the same type of access to transportation or the access to good foods or the access to even healthcare. We know that 1 in 2 men and 1 in 3 women will get cancer in their lifetime. When it comes to the group dying most from lung cancer, African-American men. The group dying most from breast cancer, African-American women.
If you were to point to 2-3 steps that you think are critical steps that can move the needle, what would you say?
Things like the expanded healthcare that we've actually had is a good thing in the context of giving people access to care. Number 2, we're going to actually have to think that what we did with COVID, we're going to have to repeat for cancer. And in fact, that wasn't just a drop in and drop out. That was a consistent effort of having boots on the ground, working with the community to come up with the solutions. That's 2. And the last one is an easy one. If we commit to this work of committing to our communities and working with them, I think we can actually see and move the needle in the context of reducing the burden of cancer.
Many experts say that one of the major impediments to health equity is the fact that some communities are not educated about their health or they don't have that literacy.
What I think, it's a new reframing of the knowledge that has to be gained on both sides. It is not going to be enough for, quote, just the community to be more literate about the science if the scientists and the health systems are illiterate to the struggles, the structures within our communities. But if we're really looking for the real benefit of reducing disparities, we have to have not only health literacy, but community literacy, meaning from the health systems, from the hospitals, the academic institutions that are all well-meaning, but are very illiterate about those communities and about the streets in which they say they want to make impact.
So what lessons have you learned that perhaps others can replicate?
Communicate in the language of the people. We usually don't talk. We usually talk at. We don't speak to. We speak over. And so the context of having the humility and the grace to understand that we need to work with and learn from our community is actually central. The other thing I learned is that by working with our community and then taking that information and giving it back to the community, that's when we're going to see some success. And then the last thing is, showing up just for the crisis is not going to ever win trust. You need to be there before there's a crisis, during the crisis, after the crisis, and then after that. I think if we're going to reduce mistrust, it's going to be showing the communities how much we care in a consistent and sustainable fashion.
Dr. Robert Winn, what is your final message?
I think that there's reasons to be hopeful. The fact of the matter is, in my lifetime, I've had a front row seat and talking to patients who had lung cancer when I was a medical student and understanding that that was the end of the road. There was nothing to offer. I have now a multiple toolkit of available things that I can use, including even better chemotherapy. That now means that people are not just surviving their cancer, but thriving, when only 10, 15, 20 years ago, it was a death sentence. When I think about hope, the hope isn't rooted in some sort of pie in the sky. It's rooted in what I see every day. and the advances that science has really made in people.
Dr. Robert Winn, thank you so much. We appreciate your time.
Thank you so much.
Now, in acknowledgement of Dr. Winn's work, the Bristol-Myers Squibb Foundation renamed their $100 million five-year initiative to increase diversity in clinical trials the Robert A. Winn Diversity in Clinical Trials Award Program. That's our health report for today. To stay in touch, find me on Twitter at Linord Moudou.